Obstructive sleep apnea. RC is a 32-year-old G1P1001 who presents to the primary care clinic today complaining of tiredness and feeling more depressed than usual. Although she reports she isn't currently engaged in any depression treatment, although she's found medication and therapy useful in the past. She has an 18-month-old daughter and had assumed her tiredness was just related to being a mom, but says it's been getting worse over the past couple of months. For vitals, her blood pressure is 125/82, heart rate 74, respiratory rate 16, O2 saturation 99% on room air, temperature 98.5, BMI of 32. Her past medical history includes PCOS and depression. For medications, she reports taking melatonin nightly to fall asleep, but isn't sure of the dose she's been taking. And her only allergy is to penicillin, to which her reaction is hives. On physical exam, RC is alert and oriented, generally well appearing, with no apparent distress. Cranial nerves 2 through 10 are intact with no vocal deficits, and gait appears normal. Her head is normocephalic and atraumatic. Tympanic membranes are intact, with a pearly gray cone of light. Perla EOM's intact. Tonsils are 2+. Her neck is 16 inches. For cardiovascular, S1 and S2 are clear to auscultation, regular rate and rhythm with no murmurs, rubs, or gallops. Capillary refill is less than 2 seconds in all extremities. Respiratory, clear to auscultation in all fields, resonant on percussion, normal excursion. Her abdomen is soft and non-tender with no hepatosplenomegaly. For skin, we noted bilateral abdominal striae, but no lesions, erythema, or edema. Obstructive sleep apnea is a common sleep disorder that involves upper airway collapse, which leads to apneas, hypoapneas, and effort-related nighttime awakenings. So apneas are the temporary cessation of breathing, and they can be obstructive, where there's continued respiratory effort throughout the event, there's just a blockage to the airway, or central, where there's a lack or absence of respiratory effort during the event. And then a mixed apnea is a combination. So there's no respiratory effort at the beginning, but then the person gets respiratory effort in the second part of the event. A hypoapnea is abnormally slow or shallow breathing, and effort-related nighttime awakenings are waking up because of that decreased ability to breathe. Central apneas is a totally separate diagnosis from OSA and are usually caused by other medical conditions or drug or alcohol use. And we differentiate between the two using sleep studies that can measure the waveforms while people are asleep and breathing. To classify OSA, we use the apnea-hypoapnea index. So it divides the total number of apneas and hypoapneas during the night by the number of hours slept for. And then based on how much the AHI index is, that will determine the rating for someone's level of OSA. Sleep apnea is the most common sleep-related breathing disorder, affecting 15 to 30% of males and 10 to 15% of females in the US, and approximately 936 million people worldwide. After menopause, the incidence between males and females equals out, and the prevalence of OSA is increasing. Risk factors for OSA include being male, obesity, older in age, upper airway abnormalities, smoking, and pregnancy. And then there's another category of conditions that are not necessarily a risk for sleep apnea, but have been demonstrated to at least be correlative with sleep apnea. So we see them at increased prevalence, and those are congestive heart failure, hypertension, end-stage kidney disease, hypothyroidism, diabetes, COPD, asthma, Parkinson's, PCOS, and pregnancy. In the 1800s, OSA was called Pickwickian syndrome, and it was named after a character, Fat Boy Joe, from Charles Dickens's The Pickwick Papers. And the condition wasn't then rediscovered until the 1950s and 60s, when we discovered that there was a link between breathing and obesity, but it wasn't connected to sleep at that time. The sleep, breathing, and neuroscience research in the 1970s and 1980s was where the modern understanding of OSA began to develop, and we were able to correlate OSA with sleep stages and realize the overall prevalence of the disease. The pathophysiology of OSA is not completely understood. but is likely to be a combination of both anatomical factors and neuromuscular dysfunction. So during normal sleep, the upper airway muscles become more relaxed and compliant, so the size of the lumen decreases as those muscles become more lax. And in anatomically susceptible individuals, the airway can't compensate for that and ends up closing completely, leading to those obstructive apneas. So the decrease in respiration then leads to hypoxemia and hypercapnia. And that ischemia reperfusion cycle causes the production of free radicals, which are inflammatory. And those inflammatory free radicals are what causes the major sequelae of OSA, like cardiovascular disease, metabolic disease, and neurocognitive dysfunction. Signs and symptoms include daytime sleepiness, snoring, gasping, or choking during sleep, morning headaches, insomnia, decreased concentration, memory loss, and decreased libido. On physical exam, people are likely to have a BMI of greater than 30, a neck circumference of greater than 16 inches in females or greater than 17 inches in males, a large waist circumference. They might have other airway blockages, so macroglossia, tonsillar hypertrophy, retrognathia or micrognathia, high or narrow palate, or nasal septal deviation and nasal polyps. And they also might have signs and symptoms of associated conditions like heart failure, hypertension, and pulmonary hypertension. Many conditions mimic OSA, so there are numerous conditions that produce excessive daytime fatigue, like sleep disorders such as RLS, insomnia, and narcolepsy, or mood disorders like depression. There are also conditions that cause abrupt awakenings during the night, like panic attacks and GERD, which might be hard for patients to differentiate the cause of their sudden awakening. And it's also important to remember that many patients with OSA snore while they're sleeping, but most people who snore do not have sleep apnea. Complications include daytime sleepiness, which shouldn't be minimized and can have significant consequences, such as getting into a car accident because they fall asleep. People can also have worsened cognition, mood disorders, hypertension, cardiovascular disease, stroke and heart failure, pulmonary hypertension, metabolic syndrome, or type 2 diabetes. They have an increase in all-cause mortality, an increase in non-alcoholic fatty liver disease, gout, and increased risk for pregnancy complications. To diagnose OSA, we can either do a sleep study in the laboratory with laboratory polysomnography or at-home testing with a portable monitor. PSG evaluation in the lab includes EEG, EOG, chin electromyogram, airflow, oxygen saturation, respiratory effort, and ECG or heart rate. And a diagnosis is confirmed if a person has greater than 15 obstructive events per hour, or there's a lower threshold of greater than 5 obstructive events per hour if they have accompanying reported symptoms. Laboratory PSG testing is preferred for patients who have significant comorbidities, for mission-critical workers such as drivers, police, airline pilots, train conductors, and can be conducted either as a full night diagnostic exam or can be a split night where half is diagnostic and half is with therapeutic positive airway pressure to help the clinician determine what someone's CPAP settings should be. The other option is the portable monitor. There's no EEG with that if someone's at home, so apneic events are calculated over the testing time, not sleep time, which can lead to more false positives. But it's best for patients with a high probability of moderate to severe OSA and no comorbidities. It might underestimate the severity. So if you're highly clinically suspicious, but the PM is negative, it would be appropriate to have a patient come in for a PSG. And a lot of insurances require a PM first, so that's a good thing to think about. You might have to do it anyways before ordering a PSG, even if you think that would be appropriate for your patient. Next, we'll move to discussing how we diagnose RC. She doesn't want to come in for a sleep study because of her young child, and since she doesn't have significant comorbidities or work in a mission-critical position, she would be eligible for the PM evaluation at home. She does that, and the PM evaluation records an average of 8 apneas per hour, which along with RC's reported symptoms put her at the mild sleep apnea category. and a PSG isn't indicated at this time, but could be if there were difficulties with treatment or there was concern that there was a more severe OSA than the PM had revealed. The USPSTF and American Academy of Sleep Medicine don't currently recommend screening asymptomatic adults, but for patients with a higher risk of OSA, there may be a role for inquiring about snoring, daytime sleepiness, and evaluating hypertension and obesity. And then if you suspect OSA, you would administer the Epworth Sleepiness Scale and potentially move to conduct a full sleep evaluation along with your physical. The first-line treatment for OSA is positive airway pressure, and there are 3 types. So there's continuous positive airway pressure, which is CPAP, or BPAP, which is bilevel. And note that BPAP is not the same as BiPAP. BiPAP is a specific brand of BPAP or bilevel positive airway pressure. And then the third kind is auto-titrating positive airway pressure. CPAP is the most commonly used, and that's largely because it's the best studied and has the most consistently positive outcomes. Adherence is a big issue with positive airway pressure. About 20 to 40% of patients don't use their device, and far more than that use it inconsistently or only for part of the night. Average nightly use is about 4 hours. Frequent follow-up is then required in the first couple of weeks to help manage side effects and help people figure out strategies that they can be adherent in their life. And after symptoms resolve, then you can just continue monitoring with annual visits while someone is maintained on their positive airway pressure treatment. There is also a role for lifestyle modification in the treatment and symptom improvement in OSA, and that includes smoking cessation, weight loss, where we see that the benefits persist even if some weight is gained back, even as much as 50% of the initial weight is regained. And that's important to remind your patients because sustained weight loss is really hard for people and pretty rare, so encouraging folks that they can still really improve their outcomes by taking this initial step, even if they aren't able to maintain at that level, is important. Although we do see that that benefit is most significant for folks with mild or moderate OSA and less so for people with severe OSA. Exercise can also be helpful. People like to limit their alcohol, benzodiazepine, and sedating antihistamine use, as those can all sedate and therefore worsen OSA and thus worsen daytime sleepiness. And it's important to encourage a sleep position that's non-supine for patients. Other treatment modalities include using oral appliances like mandibular advancement devices or tongue retaining devices to prevent the obstruction, or considering surgery. And that's usually only considered for people who have failed 3 months of therapy with CPAP and oral appliances. And it's most effective in patients with severe OSA and a direct obstruction, so large tonsils or something else clearly identifiable. In terms of pharmacotherapy, no medications have been shown to be more effective than CPAP or oral appliances. Many medications have been studied, including theophylline, which would directly stimulate respiratory drive, and dysparamiine, which would reduce upper airway collapse, and also antimuscarinics have been studied. So for RC, our assessment is that she has mild obstructive sleep apnea, keeping in mind that because she had a PM at home study, this might be underestimating her true level of disease. But for now, we're going to proceed with the assumption of a mild level OSA. So the plan for her will be CPAP, since that's first line. We'll initiate it, and we want to really emphasize how we can be supportive to her and coming up with a plan for how she can be adherent and make this work in her life so she can stay consistent with this treatment. And it's also important to discuss the array of lifestyle modifications that might help improve OSA and really explore RC's interest in making any of those lifestyle changes. We would advise her that she could continue to take the melatonin as long as she's checking and taking it at the advised dosage, but she might find she doesn't need it as much as her OSA symptoms hopefully improve with CPAP. And we want her to continue to monitor her mood symptoms because those might be related to OSA, but she might just be in a period of depression in her life, and we should offer depression treatment if that's the case for her. These are the references we used for our presentation. Thank you so much.